All right, we'll go ahead and get started. Welcome. Good afternoon. This webinar is hosted by the Great Plains Quality Innovation Network. We are the Centers for Medicare and Medicaid Services Quality Innovation Network Quality Improvement Organization serving the states of North and South Dakota. My name is Carrie McDermott. I'm our Communications Director, and I want to thank you again for joining us today. A few housekeeping items. We are recording today's session. We will send the link to the recording to all registrants tomorrow or Thursday once we get it added to our website. Please mute your lines during today's presentation and then feel free to unmute if you have a question at the end of Tasha's presentation. And if you have any questions or comments, please add them into the chat. We'll make sure to relay them onto our presenter today and allow time to respond at the end of today's session. Again, thank you for joining our conversation today on building bridges and enhancing care together. This webinar came as a result of a suggestion we got on a previous learning event where one of our participants asked us to provide education on how we can better understand and partner with IHS facilities in the Dakotas. So that's how this came to be. Our presenter today is Tasha Peltier. She is Hunkpapa Lakota and a citizen of the Standing Rock Nation. She holds a master's degree in public health with a specialization in American Indian public health. She serves as a quality improvement specialist with Quality Health Associates of North Dakota, which is part of the Great Plains Quinn. And she has been working in healthcare quality improvement since 2015. She focuses on reducing disparities in diabetes care, improving colorectal cancer screening rates, and improving the quality of care provided with IHS hospitals in North Dakota. And Tasha is my colleague, and I'm super excited to hear from her today. And Tasha, I'll turn it over to you to start your presentation. And if you want to add anything to your experience as to what I just relayed.
Awesome. Thanks, Carrie. Well, welcome everybody. First of all, I want to thank you for spending time with us today. And one of the things I just want to start off mentioning is that, you know, as Carrie mentioned, I've been working in this area since about 2015. And a thing that I've consistently recognized is that there is varied understanding of the healthcare delivery within tribal communities and, you know, a lot of questions and maybe even misunderstandings of what that looks like. And so I've really tried my best to kind of be a bridge builder, I guess, so to speak, in those gaps in knowledge and understanding, and really try to help bridge those gaps, like I just mentioned. And so that's really what today is about. Today is about sharing information, really taking a step back, looking at the big picture of things, and hopefully encouraging some of that relationship building. And so really the objectives for today is to help you as the audience to understand those very unique aspects of healthcare delivery within both Indian Health Service, but also tribally operated healthcare organizations, which we'll talk a little bit more in detail later on. And then hopefully, like I said, I want to really acknowledge or recognize those opportunities for relationship building and collaboration to hopefully help address some of the gaps that we identify and ultimately improve the health outcomes for Native American patients and really improve the overall experience for everybody involved, including providers, healthcare systems, families. And so that's really what today's discussion is going to be about. So before we get started, I really think it's important to kind of outline and lay the framework for understanding this unique relationship that American Indians, Alaska Natives have with the federal government. This relationship is sometimes referred to as a trust responsibility or a trust relationship, and it's really been long recognized in various legal documents and proceedings, you know, so this is a well-known and well-documented relationship. It's described sometimes as the federal government having a guardianship role, but really what that means is that they're committed to providing various services. And so even though when we talk about, you know, the federal government serving as a guardian, the federal government still acknowledges that tribes have the right, the US Constitution recognizes that tribes have the right to, with very few exceptions, they have the same powers as federal and state governments, and they have the right to regulate their own internal affairs. So they basically have the right to govern themselves. The only unique piece of that is sometimes those resources come from the federal government. So we'll talk a little bit more about that as we get more in depth into this information. But I just think it's really important, to point that out. So in essence, tribal nations, when we visualize what that looks like, sometimes we think federal government, states, and maybe tribes under the states because we exist within states, but really tribes are not on the same level as states. They actually have unique political classes. They are essentially domestic nations within a nation that have the ability to create their own laws, develop and operate their own infrastructure like housing, legal justice systems, educations, etc. So hopefully that paints kind of a clear picture of how tribes exist within this current day United States. Another important piece I always like to share is, I'm a really visual person, and so I'm going to try to use as many visuals today as I can. And so these are a few maps. What I'm trying to relay is what did these lands look like prior to European contact, prior to 1492, and really trying to relay this visual that there were several indigenous tribes, groups, people that inhabited these lands prior to European contact. And you can see that, there were several, there's variations of what that looked like, but I just wanted to paint that picture of what it looked like. And then fast forward to present day. So when you look, disclaimer, it's really hard to find an accurate map of tribal, whether it's federal tribal lands or state recognized tribal lands, but it's really difficult to find a map that accurately represents this. This is the best I could do. So note there are a few discrepancies in here, but it gives you the overall picture of how much that's changed, right? So how much that the occupancy of those lands has changed and what that looks like present day. And this is relevant because one of the things when we talk about treaty rights or the ability to receive things like healthcare, I hear things like Native Americans receive free healthcare, and really it's not free healthcare. I want to reiterate that this is just one of the things that was promised in exchange for the tremendous amount of land and natural resources. And so again, that's what leads to this unique trust responsibility that the federal government has with tribes. So because hundreds of millions of acres of land were ceded over to the federal government in turn said, in the form of treaties and trust obligations, they promised to provide various supports. And one of the major support areas that they promised was healthcare. Of course, there's other general social supports that were promised, like education and things like that. But today we're going to focus on healthcare. And it's also important to understand that sometimes the land was not ceded, so unceded, or it was taken illegally or unethically. And so this has really contributed to mistrust, strained relationships, various power struggles. And one really good example of this in our area is what we call Pahasapa, or the Black Hills of South Dakota. So this is a really culturally significant place that holds, things like the creation story for the Oceti tribes. And originally it was designated, because of that, it was designated as part of the Great Sioux Nation. But once, things like gold was discovered, it really became desirable. And the rest is history, right? We know that tribes do not occupy or do not own those lands present day. So that's just one example of some of the tumultuous relationships that we have seen between tribes and the federal government. This is another image that I like to use when I'm talking about this content, and it's really just a timeline that shows how Indigenous peoples, Native American, Alaska Native American Indians are the most policy people in this nation, right? So we're the most regulated, and this timeline really does a good job of just doing a high-level overview of that. There are so many specific, unique components that we could go into, but I really wanted to keep it high level for the discussion today. But it just kind of takes us through the ebbs and flows that we've seen. So we'll start on the far left with the pre-colonial period or pre-European contact. We saw that just as the map kind of showed, Indigenous communities or peoples were able to coexist, right? We all, not to say that there wasn't conflict, there was always conflict, but we were able to coexist, we were able to figure things out. And one of the big things that I want to point out is a lot of our people were self-sufficient. So like when I look at my community or my people, of the Oceti-Sakowin tribes, we were hunters and gatherers. We moved among the land for survival. We paid attention to the land. We had, this reciprocal relationship with the land. It provided for us and helped, us sustain ourselves, but we also in turn took care of the land and knew that we had to not take too much and, those kinds of things. And so that was kind of the relationship and what our existence looked like at that time. And then we moved into this colonization period, right, where we've seen things like the doctrine of discovery. We started to see people forcibly displaced from their ancestral lands. We saw the loss of lives, culture, traditional ways of living, right? And then you move into that allotment and assimilation period. And we started to see really aggressive efforts to end tribal sovereignty and to really assimilate Indigenous peoples into mainstream society. And this was really conflicting for a lot of people, right? It started to introduce a different relationship with the land, more ownership and more sedentary living. And this is also when we started to see children being taken from their families and put into boarding schools. And there was a tremendous amount of trauma that was inflicted on our Indigenous families during this time. And it's important to acknowledge this because this trauma that we experienced or our ancestors experienced, we know that's directly related to some of the social ills that we see within our communities today, and it's important to make that connection. And then we move on into the Indian reorganization period, right? So this is where things like the Miriam report really highlighted how bad things were for Indigenous people. And essentially this report, I think it was like an 800-page report, found that generally the federal government was failing at its goals of protecting Native Americans and their land, their resources, both personal and cultural. And so we moved into, so people started to recognize that and started to think, what are we going to do? They started to think about reorganizing things. How are we going to reinitiate tribal governments? What does that look like? But for a brief period, we moved into what's called the termination period, where some government officials thought it would be better to just terminate the responsibility and say, we are no longer going to provide, support to Indigenous peoples. And really tried to terminate that responsibility. We saw, I think, somewhere around 100 tribes dissolved. And we just saw a lot of negative impacts. Luckily, that didn't last very long, I think around 15 years or so, and that policy was terminated or largely abandoned in the 1960s. And we started to see this shift towards self-determination policy. Which we're going to get more into detail about this, but this is kind of the era that we see right now, right? This is when we start to recognize that, really to empower Native American tribes with greater control over their own affairs and decision making. This self-determination era represented a really significant change in federal and tribal relations. We started to see things like tribal consultation, right? Bringing tribes to the table and recognize that nobody was more well-positioned to come up with solutions than the tribes themselves, the people that live in those communities themselves. And so I think, again, this is not all-encompassing. This is a very high-level timeline, but just kind of to bring you through, like I said, the ebbs and flows of what we've seen historically. And one of the last comments I want to make is I also, I think that we think about these things as so far in the past, right? These are historical events. They happened so long ago, but one of the most alarming things for me, I think, was when I learned about, one example is the American Indian Religious Freedom Act of 1978. So 4 years, I was born in 1982. 4 years before I was born, it was still illegal for people to practice ceremony, to do any spiritual things that are connected to their spirituality. And that to me was really eye-opening, because I even myself would think of things like how long ago things happened. But just remembering that these things, we're not even one generation removed from some of these things. And when you look at some of the traumas that I mentioned, those things carry on. And we talk about things like generational trauma, those things are impacting generations to come. And so it's really important for us to acknowledge and make those connections. We don't want to live there. We don't want to stay there, but we have to acknowledge those things to have conversations about moving forward and coming up with solutions to make things better. And so it's not the funnest part of my job. I don't like talking about all of these things, but again, it's really necessary for us to have these conversations. So now the fun stuff. I'll just, again, a disclaimer. If you don't like policy, I'm sorry, but these are just some of the specific policy, federal policy that really impact the delivery of healthcare. And so we're going to start with the Snyder Act of 1921. This was the first formal legislative authority that allowed health services to be provided to Native Americans. And it was really significant because, number one, it allowed Congress to actually appropriate funding to address American Indian Alaska Native health on a recurring basis, right? Prior to that, there was no actual funding mechanism. And so now this really created that. One of the unique things, or one of the kind of interesting things to me, is that at this time, all of those activities were held under the Department of War. And I'm assuming, and I think some of the things I've read, it's because a lot of the interactions between the federal government and tribes up until that point were dealt with conflict, right? And so that was the appropriate place to put those things at that time, I guess. But what we did see was in the Transfer Act of 1954, this is where all of those things moved, all the responsibility transitioned from the Department of War over to the Public Health Service, which is a much more appropriate place for those things to be housed. And so that now the responsibility of oversight and all of those things fell under the Surgeon General. And so it's just really reiterating that, all functions, responsibilities, authorities, and duties relating to the maintenance and operations of hospital and health facilities for Indians and the conservation of Indian health shall be administered by the Surgeon General of the United States Public Health Service. So again, much more appropriate than a Department of War. And I think this is also significant because it also was starting to expand their scope of services. So scope of, services provided. And really two of the main areas that it expanded to was the construction of facilities. So when you think about health and healthcare, right, you need a place to provide those services. So that introduced the construction of healthcare facilities. And then also Public Law 86121 also added water and sanitation services. And really why this is important is because, like I mentioned before, people like the Oceti-Sakowin people were very, we moved among the land. We never stayed in one place. We never lived in our own waste, right? And then when you introduce reservations and kind of had a more sedentary lifestyle, there became, we started to see things like preventable waterborne diseases. There is inadequate access to safe, clean drinking water. There was inadequate wastewater treatment or disposal. And so we started to see diseases that were stemming from that. And so that was a huge red flag. And so they initiated things like water and sanitation services. And then in 1975, we saw the introduction of the Indian Self-Determination and Education Assistance Act, or also known as ISDEA. And so I talked a little bit about that in my timeline. And so this is really probably the most significant law that affects how those health services were provided. So it really afforded the tribes to assume the management of certain programs. And it really directed the Secretaries of Interior and Health and Human Services to enter in what's called self-determination contracts at the request of any tribe. So basically, this gave the tribes the ability to say, hey, we want to manage these services. So, it gave them the opportunity in a couple different ways to be able to receive that funding and manage it and operate those programs themselves. And so how we see that show up today is it's Public Law 93638, but a lot of times you'll hear that's a 638 program, and that just means that it's tribally operated. And so in our areas, there's a few different, I'm more familiar with North Dakota. We do have a couple clinics in North Dakota that are tribally operated. The MHA Nation operates its clinic through the tribe, and then Spirit Lake Nation operates their clinic through the tribe. And so these are just two examples of how a tribe exerted itself, its tribal sovereignty and self-determination by entering into either a compact or a contract with the federal government. And really, it just, again, there's nobody better positioned to address your own social, economic, and cultural needs than the tribe themselves, the people themselves. And so we've seen this across the nation. And actually, since the introduction of ISDEA, we've started to see a tremendous increase in tribally operated healthcare facilities, and Indian Health Service, or federally operated facilities, are kind of on the the down spiral. So we're seeing less and less federally operated facilities and more tribally operated facilities. And then just a little bit more information about, again, the ISDEA is just really declaring its commitment to maintaining the federal government's unique and continuing relationship with and responsibility to the Indian people through the establishment of a meaningful Indian self-determination policy, which will permit an orderly transition from federal domination of programs for and services to Indians to effective and meaningful participation by the Indian people in the planning, conduct, and administration of these programs and services. And then next in 1976, we saw the Indian Healthcare Improvement Act, and this was really the result of over 500 federally recognized tribes banding together, lobbying for additional funding in healthcare and education and other things. But really, they were saying, we don't have adequate resources to be addressing the things that we need to address. And so they fought hard, and they were able to, get some changes. It's provided the programmatic and the legal framework for carrying out the federal government's trust responsibility for Indian health, and really reiterated the responsibility to provide the highest possible health status to Indians and provide existing Indian health services with all resources necessary to affect that policy. One of the things that I didn't get to mention in the timeline was there was a time period where through attempted assimilation, there was a lot of tribal members were encouraged to move and relocate to urban areas. So there was an urban relocation program that would give you funding and money to move to these urban areas to better, more easily assimilate into mainstream society. And so we saw a lot of people moving to Denver and San Francisco, and there were just all these, Chicago, there were all these pockets of urban places that this program would send you to. And so what we saw was that all of these Native Americans were in these urban communities, and they had no access to these treaty rights like healthcare. And so the Indian Healthcare Improvement Act initiated or established the urban Indian health programs. And so we see those throughout the nation today. So that's where the term ITU comes from. So in IHS, tribally operated, and then U is urban program. So in South Dakota, like Sioux Falls has an urban Indian health program to serve some of the urban population there. And another thing that was really significant about this policy was that it allowed, up until this point, IHS tribal organizations were not able to bill Medicaid and Medicare. And anybody who runs a healthcare facility knows how important that third-party revenue is for sustainability. And so this was the first time that these facilities and those tribal members were able to apply for and use those services under IHS tribal and urban facilities. And so just a reminder, that even though Americans, Indians, and Alaska Natives qualify for federal healthcare services through the Department of Health and Human Services, they are also citizens of the United States and therefore should be eligible to participate in all public, private, and state health programs that are available to the general population. So that was a huge, significant change in the delivery of care. And then this Indian Healthcare Improvement Act was also permanently reauthorized with the Affordable Care Act of 2010, which was also significant. And so now we're going to move into some of the, I gave a very fast and furious overview of some of the history. Now we're going to talk about what's happening right now. What are some of the current barriers or problems that we continue to see? And one of those is the funding structure. So the Indian Health Service, tribal healthcare systems are funded through what's called they're discretionary funded. Basically, it means that they're subject to congressional interference, right? So they're subject to the annual appropriation process. So it means that they have to, fight for their funding on a year-to-year basis. And actually until December of 2022, they were the only federal program that had to operate without the basic certainty of funding from one year to the next. So in December of 22, what we saw was they passed for Indian Health Service to receive advanced appropriations, meaning that they will be funded for the next year. So any kinds of government shutdowns, things like that, are not going to impact their budget for that year, which was significant, was huge. It's still not where we want to see it, but that was big. So they're not having a disruption in their services when there's government shutdowns, different things like that. And so, but they are still, they still have to go through that annual appropriations process. And that's problematic for a variety of reasons. I think, it's just introduces a lot of uncertainty. It's hard to sustain long-term healthcare programs effectively when you don't know what your funding is going to be. And I think one of the other maybe less known things is that Congress is approving these things. And a lot of times when we look at Indian Health Service, tribal facilities, urban facilities, there's a lot of congressmen that don't have reservations or ITU facilities within their state. So they're ultimately voting on something that has nothing to do or doesn't impact their constituents at all. And so that can be problematic when they're making decisions about funding that doesn't impact the states that they're representing. And so those are just a few little unique nuances that we see are barriers. And then this is a large system. This is a huge, when you look at Indian Health Service or the everything that falls under that umbrella of ITU, this is a large system that's serving communities with unique people, with unique cultures, unique languages, unique demographics, unique geography, and so imagine, this is a huge system that's trying to meet the needs of all these very, very, very different communities, and you're trying to standardize things. There's just a lot. It's difficult to do that, right? And so, that's one of the big issues that we see in having such a large healthcare system is it's not easy to provide that standardized care throughout across such a large span of reach. When we look at another barrier that we see, and I think we see this across healthcare systems, across the board, is workforce shortages. But when we look at tribal communities and some of these facilities, is when we have on reservations facilities specifically, that can be difficult to attract the workforce to our communities. We have very remote communities. There's, difficulties with housing. Some Indian Health Service and tribal facilities may have on-campus housing. But when you look at healthcare professionals or people that are wanting to work in these kinds of professions, sometimes they're young families, they want to build a home, they want to, there's a lot of things that they want to provide as they start their careers or as they, have their careers. And sometimes our communities don't offer those things, and it's really difficult. One example I can think about is, I'm from Standing Rock. I work very closely with the Standing Rock Service Unit, and if they're commuting or traveling, they're commuting anywhere from 50 to 60 miles one way, right? And so when you think about if you're a you have a young family, that's an extra 2 hours on the road a day, in addition to maybe your 8-hour day. Sometimes it's a 10-hour day, and that's really a lot of strain to put on somebody. And so those are some of the barriers that I think we face. And I know that's an issue with rural healthcare across the nation. And it's even more complicated when we talk about trust land and, what does building a house on a reservation look like for a non-native person? There's just a lot of complicated little nuances that just make it really difficult to attract and retain some of that workforce. There's also infrastructure challenges that we see. So not only, I know I mentioned a little bit about, the construction of facilities, but when you think about the vast amount of communities you're providing care to, the amount of facilities that need to be built and taken care of, and also the information technology that's required. We know in the medical industry and technology in general is just ever changing. It moves so fast. It's always growing, and it's so complicated to keep up with the most recent advancements. And so when we look at some of these facilities within, Indian Health Service and tribal facilities, we see that they may not have the best of the best, or they don't have the most advanced. For example, the EHR that IHS is currently using is very outdated, right? Luckily, they're on the brink of, they're implementing a new EHR, and it's on the horizon, and that's going to be great, and everybody's so excited, but that's going to take time too. But those are some infrastructure challenges that can present barriers when sharing information, or just different things like that. And so those are again some unique barriers that we see. And then lastly, we can see limited ability to address some of the social drivers of health. You know, there's a lot of national conversation around the need to address, you know, social issues to allow people to prioritize their health, because, you know, let's face it, we know that, you know, an individual's ability to prioritize their health is a privilege that not everybody has, right? And so we've been having a lot of conversations and really thinking about what does that look like. Well, when you look at communities that are facing different issues like poverty, you know, lack of access to housing, lack of educational opportunities, you know, just all of, again, these things that are direct impacts of the trauma that have been inflicted on our communities, you know, that makes it really difficult to address some of these social challenges, right? And if you don't have the infrastructure in place community-wide, you know, it can be even more difficult. And so these are just a few, like I said, it's not all encompassing of a list, but these are a few of the top things that I wanted to make sure that we talked about today when we talk about current day problems for the healthcare delivery within these communities. Again, with the visuals, and apologies, this is not the most up to date. This is data from 2017, but I always have a really hard time finding newer versions of these, but this is just to give you a picture. This is a comparison of you know, expenditures per capita between federal programs. So if you look on the far left, that's Medicare, and this is spending per beneficiary, right? So you see about, you know, over $12,000 per beneficiary on Medicare. We see the national health spending per capita is over $9,000. The VA is over $8,000. Medicaid is spending about $7,700 per enrollee. And then the FDI benchmark per user is about 7,500, and way on the right, we see two numbers, and these are actual IHS spending per user. So for an IHS beneficiary, it's actually about $3,300 per year. And then that way right other is really accounting for, like I mentioned earlier, the budget includes facilities management, you know, building and maintaining facilities. So that's what that other $519 per user is accounting for, is those facilities. And so, but this really, you know, that what I want to portray here is that we have healthcare services that are severely under-resourced and sometimes are expected to provide care and help manage some of the, you know, highest healthcare disparities that we see in our communities, right, or across our states and sometimes the nation. And so that's not really a recipe for progress or a recipe for change when we see some of the highest, you know, we see high rates of heart disease, cancer, you know, a lot of these things in our communities, but we don't have the resources to address those things, let alone work on prevention, right? So and this has been an issue that we've seen for a long time, and there's you know, people that are actively lobbying and actively, you know, fighting to change that. But right now, and again, I know we've seen budget increases since 2017, so I know that this number isn't quite as drastic, but it's probably very similar. And apologies for not having more up-to-date numbers for that. And here's another visual representation. This is just breaking it down into the four federal health programs. So we have IHS, the VA, Medicare, and Medicaid, and it's really breaking it down into entitlement versus non-entitlement programs. So the VA and IHS are non-entitlement programs, and then you have Medicare and Medicaid, which are entitlement programs. And again, it's just relaying that huge disparity in spending per capita for all of those programs. IHS is at the bottom of that list for sure. And then one more visual representation. I talked a lot about barriers, you know, infrastructure barriers that we see that are related to the facilities that we're providing care in. So you'll see this graph shows the blue lines is the total healthcare facility construction need, right? So since 1994, we've seen a steady increase in the need for that. And again, it's related to, you know, different technologies, you know, aging facilities. A lot of these facilities were built maybe in the 60s, 70s, and as they're aging, the need for construction is increasing. There's just a lot of things that are impacting that need. But what we see is that orange line that maybe, I don't even know if you're able to see it, but the orange bar is actually what the total healthcare facility construction appropriations are, meaning that's what Congress is appropriating to work on those healthcare facilities. So as you can see, as time goes on, it gets further and further. The need and the actual funding appropriations are getting further and further apart. And that's significant when you're talking about meeting the needs of your patients. And this is what is going to lead into probably the meat of our discussion, or the biggest thing that we want to talk about today is programs like purchase referred care. And so when you have facilities that can't meet the needs of their patients, like I mentioned on the earlier slide, that are outdated, that don't have the technologies, there is a need for IHS and tribal facilities to purchase services from other healthcare entities, right? Other private sector facilities. And the program that makes that possible is Purchase Referred Care, or PRC. It was previously known as Contract Health Services, but basically this is a program that's designed to address those healthcare needs of eligible Native American and Alaska Native individuals. Some cases, like I said, people require services that aren't available at their local health service facility. And so to bridge this gap, the PRC program allows those individuals to receive those necessary medical care outside of that IHS or tribal facility. And so really, what I want to highlight here is that so this program exists, but there's eligibility criteria. There is a referral and an approval process that has to happen, right? So it's not that, if an IHS provider refers a patient for care, that doesn't mean that's guaranteed that it's going to be paid. There's a whole process that, because there's not an infinite amount of funding, right? There is a bucket that ends. There's a bucket of money that goes away when it's gone. So there has to be a way to prioritize, what levels of care are going to be paid for. And so there's a whole process and committees, and, every facility has their own process or ways that they carry this out. But essentially there's a process that patient referrals have to go through to decide who's going to be approved for those services. And then another process to decide how that's going to be paid, or there's another process that dictates how bills get paid. And so really just want to reiterate that this PRC program is vital. It's a vital piece of ensuring that patients, eligible IHS and tribal beneficiaries, receive the care that they need, and collaboration and communication is a crucial piece in that. And so that's what today is really all about, is hopefully sharing information, helping to get, outside organizations, programs to really understand this process to a certain level, to a certain degree, so that we can hopefully help bridge those gaps in understanding. This is actually straight from the IHS website. I think it's a really good visual. I'm not going to go into great detail, but it really just shows you, again, there is steps to identify if you're eligible to receive those referral PRC program. If you're an eligible recipient of PRC, there's also a way to identify if your referral will be approved, and then also a process to identify if that service will be paid for. And so why this is important is because I think a lot of times when people look at PRC when people look at Indian Health Service or tribal healthcare, they maybe think of it as like an insurance company. And that's probably the number one message that any of the people that I work with at IHS or tribal facilities want me to relay, is that IHS is not a health insurance benefit. And so I'm going to move on to the next slide. This should be available. I think there's a link that's put in chat, so you can access this. We'll send this out at the end if you want to read this slide in more detail. But really, what we want to share, the message that we want to share, is that, again, IHS is not an insurance benefit, right? And actually, federal language requires that IHS is the payer of last resort, meaning if you're a patient that qualifies for Medicaid, even the VA, all of those payment avenues need to be exhausted before IHS can pay for any services. So there's a lot of, complexities to these situations. And so Making sure that you understand that just because a patient has been referred or that they say that their primary care provider is IHS doesn't mean that IHS is necessarily going to pay for all of the services that they receive. Just be aware that patients don't even understand that. One of the things that I think for me, I grew up on Standing Rock. I graduated from there. There are so many things that I didn't even understand or learn about, in high school. A lot of these things I learned in my graduate program, luckily, and it just really blew my mind. I never knew, a lot of these things. I thought, everybody goes to IHS and you get all of your care provided, and I didn't have any idea that there was any of these complex processes. And so I think, again, my goal is always to share this as much as I can so that we can make sure that there's no negative impacts to patients, to other healthcare facilities. We don't want to see strained relationships. And so really helping to reiterate that message, and not all services are covered. Again, I mentioned earlier, there is a end to that bucket of money. And so they have to prioritize, and they use, every facility is different, but they may use like levels, right? Level 1, 2, 3, 4, with, one being the most extreme and one being all the way down to like preventative care. Some facilities may be able to fund everything. They may have a lot of third-party revenue or different things that are supplementing their budget, and they may be able to pay for everything. And we may have other facilities that don't have the money. And so it's really on a case-by-case basis, facility by facility, patient by patient. And so, really, this is why I want to reiterate that communication is key, right? So expecting the patients to know what that process is probably not realistic. Expecting, when you look at the referring provider, whether it's IHS or tribal, expecting the receiving provider to know all that's not realistic, and vice versa. Those outside healthcare facilities that are receiving referrals from IHS and tribal healthcare, it's not realistic to assume that any information is going back and forth. And so really, I'm encouraging, in the interest of continuity of care and, good experiences between patients, providers, different healthcare facilities, really encouraging that communication piece, and I've seen it come, in a few different ways. I have a couple of suggestions here on how to build partnerships. One of the things I've seen is, different IHS and tribal healthcare facilities and private sector healthcare facilities setting up ongoing, regular, recurring meetings, right? That you share patients on an ongoing basis, so it's great to check in every now and then. One example, again, I work pretty closely with the Standing Rock Service Unit. We see that their case management team, for example, will meet with the case management teams in the Bismarck healthcare facilities, because they know a lot of their patients, whether it's by ambulance or whether it's for referrals, a lot of their patients get sent to Bismarck for various reasons. And so they try to stay on top of meeting and staying in communication and, giving updates on different things that may be changing. Another example is Standing Rock shares patients with Mobridge Regional Hospital here in Mobridge. I live in Mobridge. And so I've seen that they have ongoing meetings to, just get on the same page and maybe bring up some questions or frustrations. And it's really a good example of how just sitting down at the same table, having conversations can really promote better relationships. So do that, find out who you need to, who you're interested in, who you share patients with, or who maybe you have questions for, and reach out and try to set up those meetings, whether it's with case management, maybe it's billing, maybe it's care teams, maybe it's administration, maybe you start there, but just really thinking about building those relationships. The other opportunity is engaging in statewide types of meetings. I know I work, primarily I'm working with North Dakota kind of statewide programs, but we have several opportunities to engage, in conversation. There's tribal consultation meetings that happen, specifically like Medicaid, but they also have, quarterly tribal health director meetings where the tribal leadership is, coming together across the state and talking with state programs and IHS, and they're having conversations about what are the pain points that they're seeing, what are the issues that they're wanting to have dialogue around and to work through. And then lastly, and I know there's similar meetings in South Dakota, that's one of the things I wanted to mention. I just haven't been a part of those as closely. And then lastly, just different spaces like conferences. One of the things that I wanted to mention is that we're really fortunate. The National Indian Health Board is a huge national organization that advocates for Indigenous communities across the nation, but they are hosting their annual conference in Rapid City, South Dakota this year. And that's a big deal because I think they were in Alaska last year. They kind of bounce around to different areas. And so it's going to be here in the Great Plains this year, which is really exciting. There's, different organizations like the Great Plains Tribal Leaders Health Board that have ongoing opportunities for learning and those kinds of things. And then lastly, just, think different academic institutions or tribal organizations host different conferences. So really getting out there and learning about what's available, what's happening, and where can we have these conversations. And then a couple other places I wanted to refer you to is, the Indian Health Service website does have, both an IHS directory. If you're trying to figure out who's the CEO at this facility, I can't guarantee it'll be up to date, but at least you'll get a starting point to find out, who can I talk to about setting these meetings up. Try that IHS directory. And so we'll pop that into chat. And then there's also facility level information. So if you're wanting to know like what services are provided at a service unit, or what, you just want to learn a little bit more about a community maybe that you're sharing patients with quite frequently, go check out the facility level websites. There's variation. Some of them have a lot of information, some of them have very minimal, but just get out there and check it out. See what you can find, and hopefully this will help connect you. And I'm always a resource. Again, my goal here is to really help foster collaboration. I want to help, encourage building those relationships, because like I said earlier, it just promotes better outcomes for everybody, right? It promotes, a better situation, a scenario for all. And so I am always available to be a bridge builder, to be a contact, to hopefully help connect people if you're not quite sure who you want to talk. I may not have the answer, but I'll find maybe somebody that does. And so that's really been my role, and really just want to thank you for your time today. You can always reach out to me if you have questions. I don't know how much time we have, Carrie, for any questions, or if we have questions.
Again, if you do have a question, go ahead and put it in the chat, or you can take yourself off mute and ask Tasha a question. I don't see any in the chat, but I had it minimized. Alyssa, am I missing anything?
Yep, Sarah.
Sorry.
That's okay. Sarah just put one in there. So she asks, any suggestions of title of staff to approach for setting up meetings?
Yeah, and I think that depends, on what you're looking to address. If it's, I gave some examples earlier. Sometimes we'll see issues with maybe referral communication, where a referral is not getting to a provider, and patients are showing up and they don't have the appropriate paperwork or whatever. That may be case management, if that exists within the facility. It's really hard to, again, when I talked about how everybody's unique, each facility's staffing is even unique. Some people have patient advocates, or some facilities have patient advocates, some don't. Some have case managers, some don't. I would say your best bet, I hate to suggest going directly to the top, but everybody has a CEO. Every facility has a CEO. And so I would encourage you to, find out who the CEO is. The other option is your billing office. A lot of times billing is heavily involved in the sharing of, of course, they're the ones that are responsible for paying the bills. And so if there's questions around, bills not getting paid, those are CEO, billing office. And again, if you're looking for a specific contact at a specific service unit, I'd be more than happy to try to make a connection or identify somebody that you could contact there. But one of the last things that I didn't get to bring up is, yes, we want to promote collaboration so that everybody has a good experience, but we also want to prevent harm from happening. One of the things I think that we see consistently is because, not consistently, but we see it happen, is that patients will be referred to a facility, an outside facility, to receive care. And that facility may not know that there's all these hoops that have to happen, or, that has to be jumped through before their bill will be paid. And sometimes those processes take a long time. Anybody that, it's just the beast of the federal government, right? There's a lot, it takes time. And so we've seen where patients' bills get sent to collections, even though the responsibility for paying that bill is on the IHS. It's been approved. It's just going through this process of payment. But we've seen patients, their finances negatively impacted because, again, facilities they're not aware of that process, or there's a difference between somebody being denied coverage or payment for their service and just waiting for the process. And so just the communication on those kinds of things really will help prevent harm too for any patients or families that are involved in that referral process.
I know Sarah had a follow-up question. Sarah, did that answer your question?
Sure did. Thank you.
Great. And then
Tasha,
just
there is oh, sorry, Alyssa.
go ahead.
Oh, there is a comment in there from Stephanie Bemis. She said she would love to talk to you sometime about a collaboration that they have going on with Newtown.
Awesome. Yes, I would love to. Please reach out.
Again, if you have a question, you can go ahead and put it into the chat. And I guess I just would be remiss not to mention that Tasha was awarded a Bush Fellowship awardee for 2023. And she is going to focus on, I don't want to speak for you, but reclaiming and rebuilding wellness and health within Indigenous communities. And I believe is traveling tomorrow in relation to that, right, Tasha?
Yes, yep. I'm actually going to New Zealand tomorrow. So this time tomorrow I should be on a plane. And yeah, I think really a lot of the, focus of that, my leadership journey is really identifying, a lot of things I talked about, the historical things, right? The loss of language and culture and identity. Really, my focus is on how do we uplift those things and focus on those as strengths and really use that to drive health and wellness in our communities. And so, yeah, it's pretty interesting. I find myself working on very opposite ends of the spectrum. I work with Western healthcare systems to provide better care, but I also think about on the other end of the spectrum is how do we not center on these systems so much, but really focus on uplifting things that, have promoted resiliency and that have kept our communities alive and health, essentially alive through all of the things that our communities have been through. So.
Well, congratulations to you, and others echo that sentiment. We're proud of you and congratulate you. That's
so
amazing.
much.
I think she's one of 24, right? Total
Yes.
awardees? Yeah,
Yep.
amazing.
Yes, thank you so much. And I also wanted to make sure, we do have a few things that I referenced in my slides today that we wanted to make sure that we uplifted and shared out. One of the things that I've found very useful is, at the state level, the tribal liaisons or different positions that are dedicated to, again, being bridge builders between communities. And so for North Dakota, they have a whole community engagement team. So there are individuals that are dedicated to each of the reservations from the state Department of Health and Human Services. And so those are, I put the link in there so you can see who, what is the liaison that may be designated for a tribal community that you're trying to communicate with or that you want to build some relationships with or strengthen. And then for South Dakota, we do have an individual that has tribal liaison within her wheelhouse of duties. And so we put her information in there for you to be able to reach out and contact her if you have questions or want to know how to connect in maybe, like I mentioned, those statewide meetings or things like that. Those would be people that you could contact there. Again, there's links for the different things that I mentioned in my presentation. And then lastly, I always, this is an article that I reference quite often. It's a publication called American Indian Health Policy, Historical Trends and Contemporary Issues. It is by Dr. Donald Bourne and Dr. Frizzell. And it's really, I reference it a lot or share it because it's a really nice, easy read that's a high-level overview of some of the information that I went over today. And so I know it's dry sometimes, but it's definitely informative. And so I wanted to make sure I shared that with individuals as well.
Tasha, there is a comment from Monique Reynolds. She said you can go ahead and add me as a resource on there too.
Awesome.
So-
Thanks, Monique. Yes, so maybe what we can do when we send out the information, Carrie, I'll send you Monique's contact information. So Monique is a contact at Medicaid. So I don't remember her specific title, but she again is a bridge builder between the state Medicaid office in North Dakota and tribal communities. And so she's been a great resource for a lot of tribal leaders. So we'll make sure that you have Monique's information as well.
Awesome. All right, if we don't have any other questions, I'll give it a second. Monique is the North Dakota Tribal Medicaid Liaison.
There we go. Thanks, Mo.
All right, I guess, thank you, Tasha. Thank you, everyone, for taking the time to join us today. We will send a certificate of participation to all attendees and registrants. After today's session, I think maybe Alyssa or Kelsey will put a link to the evaluation in the chat. If you can please provide us some feedback on today's session, other topics that might be of interest related to this or any other quality improvement topic, we'll take them. A reminder, Great Plains Quinn is an approved provider of continuing education with the North Dakota Board of Examiners for nursing home administrators and the South Dakota Board of Nursing Facility Administrators. We will send the certificate to all registrants along with the recording sometime yet this week. Again, please complete the evaluation link. It's in the chat. Again, thank you, Tasha, for sharing your knowledge, your expertise, safe travels. Congratulations to you. And thanks everyone for joining us today. We will follow up with you in the next few days with some follow-up resources. So thank you again. Have a great rest of your day.
Thanks, everybody.
Thank you.